of skeletal muscle with improvement following rest. Weakness results from an antibody-mediated immunological attack directed at acetylcholine receptors in the post-synaptic membrane of the neuromuscular junction. Incidence is 2.1 to 5 per 1 lakh people in India, more common in females than males, with ratio of 6:4 ratio. Peak incidence in third decade in females and fifth decade in males. The other autoimmune disorders associated with myasthenia gravis are rheumatoid arthritis, SLE, diabetes mellitus, autoimmune thyroid disease, syndrome of inappropriate dietetic hormone, Cushing syndrome, hypogammaglobulinemia, RBC, aplasia. Coming to etiopathogenesis, it is autoimmune disorder. It is caused by autoantibodies to nicotinic acetylcholine receptors. Here, thymus plays a role in 85% of the patient. T cell stimulation occurs against to a protein similar to embryonic acetylcholine receptors after sensitization within the thymus. It can lead to formation of the anti-acetylcholine receptor autoantibodies, which destroy the acetylcholine receptors. It can lead to impaired muscle construction after depolarization. Myasthenia gravis is classified in a clinical scenario into pediatric myasthenia gravis and adult myasthenia gravis. Pediatric myasthenia gravis again classified into neonatal transient, neonatal persistent, and juvenile myasthenia gravis. Coming to neonatal transient myasthenia gravis, babies born to mothers with myasthenia gravis will have neonatal transient myasthenia gravis. Here, main pathophysiology is circulating acetylcholine receptors autoantibodies, which are passively transferred from the mother blood. It usually present at the 12 to 48 hours after birth, last up to 2 to 4 weeks. Clinical features are feeble cry, poor feeding effort, respiratory difficult, ptosis, and facial weakness. Neonatal persistent myasthenia gravis. It is very rare, no detectable antibodies to acetylcholine receptors. Its usually onset is 2 to 3 months of life. Juvenile. It is similar to adult myasthenia gravis. Adult myasthenia gravis is classified into 4 grades by Osmerman and Jenkin. Again, it is also divided into ocular myasthenia gravis and generalized myasthenia gravis. Ocular myasthenia gravis, grade 1. It involves mainly ocular muscles. It can lead to ptosis and diplopia. Electrophysiological tests of the other muscles are negative. Ocular myasthenia gravis with peripheral muscle involvement, grade 1A. Here, mainly ocular muscles will involve and electromyography of peripheral muscles are positive, but no symptoms of peripheral muscles. Generalized myasthenia gravis, again it classified as mild, moderate, acute, fulminating, and late severe. Mild myasthenia gravis. It is slow in onset, usually ocular muscles involved, rarely peripheral muscles also involved. It is good response to drug therapy. Moderate myasthenia gravis. It is also in slow in onset, ocular involvement with bulbar and skeletal muscles also involved. No respiratory muscle involvement. Patient activity is limited. Fair response to drug therapy. It is a low mortality rate. Acute fulminating myasthenia gravis. It is a rapid in onset, progress within 6 months. Severe bulbar and skeletal muscles are involved, and respiratory muscles also be involved. Patient activity is limited, poor response to treatment. It has high mortality rate. Late severe myasthenia gravis develops 2 years after onset of group 1, group 2 symptoms. Its progress may be gradual or rapid. Severe bulbar and skeletal muscles are involved, and respiratory muscles also be involved. Patient activity is limited. Poor response to treatment, it has high mortality rate. Coming to clinical features, depending upon the muscle group, it has muscle weakness. It can lead. It characteristic is worsen on exertion, improve with rest. It is fluctuating in nature. Involvement of ocular muscles are the first manifestation in Myasthenia gravis. It can lead to ptosis and diplopia. Ptosis may be symmetrical, asymmetrical, unilateral, or bilateral, typically alternates. Diplopia, it can lead to nystagmus. Pupils are usually spared because it is smooth muscle. Involvement of bulbar muscles can lead to dysarthria, dysphagia, difficulty in chewing during attack, nasal regurgitation, involvement of the facial muscles. 15 to 20% of myasthenia gravis patients also involve limb muscles. Mainly proximal muscles are more involved than the distal muscles. It can lead to difficulty in climbing stairs, lifting hands. Weakness of the neck extensors also involved. If respiratory muscles are involved, patient will have dyspneic symptoms. Diaphragmatic involvement occur, it can lead to reduced forceful to cough, unable to produce voice. Mass effects of myasthenia gravis associated with thymoma or cough dyspnea vena cava syndrome. Cardiovascular involvement in myasthenia gravis or focal myocarditis, LV diastolic dysfunction, atrial fibrillation, AV conduction delay. Factors aggravating myasthenia gravis are physical and emotional stress, infections, pregnancy, surgery, heat, and exposure to bright sunlight. Drugs which are aggravating myasthenia gravis are quinidine, procainamide, calcium channel blockers, beta blockers, aminoglycosides, erythromycin, clindamycin, ciprofloxacin, and phenytoin. Diagnosis can be made by clinical examination, electrophysiological study, tensilon test, serological test, and ice pack test. Coming to clinical examination, fatigue after prolonged upward gaze and holding outstretched hand in abduction for 5 minutes. And there will be a decrease in vital capacity and absence of other neurological signs. Electrophysiological test. Peripheral nerves are stimulated with supramaximal stimulus of 2Hz 4 times or 2 seconds in TVF pattern. There will be a decrease in twist response 10% between the fourth and first diagnostic is of myasthenia gravis. Tensilon test. IV heterophonium 1 to 2 mg test was given followed by 8 mg IV tensile test. It is a short-acting acetylcholinesterase inhibitor. Onset occur within 30 seconds with duration of 10 minutes. Patient with myasthenia gravis show drastic improvement after IV heterophonium. Cardiac monitoring should be done and atropine should be available. Ice pack test. Based on the fact that cooling improves neuromuscular transmission. Placing ice pack for 2 minutes over eyelids causes resolution of the ptosis. Serological test. Anti-acetylcholine receptors found in 80% of patients with generalized myasthenia gravis and 50% patients with ocular myasthenia gravis. Preoperative levels more than 100 nanomilliliter per liter associated with postoperative myasthenic crisis. And muscle-specific tyrosine kinase antibodies also present in 30 to 40% of myasthenia gravis patients. Complications of myasthenia gravis. Myasthenia crisis, it is defined as respiratory muscle or bulbar muscle weakness with severe enough to necessitate intubation or to delay extubation after surgery. It can occur either spontaneously or with any one of the following precedent like surgery, infection, residual anesthetic, withholding or tapering of myasthenia gravis medication, drug known to exacerbate myasthenia gravis. In awake patient, the signs are symptoms are dyspnea, change in phonation, obstruction, weak cough, difficulty in handling secretion. It can be diagnosed with IV tensilon test, and formal neurological physiological studies may be necessary. Urgent rapid therapy with plasma exchange or intravenous immunoglobulins in addition to immunotherapy is required. And other complication is cholinergic crisis. It is mainly due to overdoses of the acetylcholinesterase inhibitor like pyridostigmine. It manifests as paradoxical weakness along with other signs of cholinergic excess, like salivation, lacrimation, urination, defecation, gastrointestinal distress, and emesis. There is no improvement of the symptom with Tensilan test, and myasthenia crisis must be discussed from the cholinergic crisis as the treatment of the two conditions is very different. The treatment of cholinergic crisis is atropine or glycopyrrolate to counteract muscarinic effects, and further anticholinergics should be held. Repeated doses of anticholinergic may be required in some patients. And the prediction of myasthenia gravis in postoperative period or vital capacity is less than 2 to 2.9 liter. Duration of myasthenia gravis more than 6 years. Pyridostigmine doses more than 750 mg per day. History of any COPD. Preoperative bulbar symptoms. History of myasthenia crisis. Intraoperative blood loss if more than 1 liter. And serum anti-acetylcholine receptors antibody more than 100 nanomillimoles per milliliter, and more pronounced decremental response on low frequency repetitive nerve stimulation. Coming to treatment, acetylcholinesterase, it is the first line of drug, and prolonged duration of acetylcholine at the post-synaptic membrane by the inhibition of acetylcholinesterase. It is the mechanism of action, and pyridostigmine dose is 30 to 120 mg per day for oral in 3 to 6 divided doses. Onset within 30 minutes, peak effects is 2 hours. The side effects are cholinergic crisis due to excess acetylcholine at the receptors, leading to persistent depolarization. Second, corticosteroids. They will reduce the amount of acetylcholine receptors autoantibodies, and it also reduces the anti-acetylcholine receptor reactivity of peripheral blood lymphocytes. The dose is 1 mg per kg or 40 mg per 40 to 60 mg per oral per day on alternative days. Immunosuppressant like azathioprine and cyclosporin also be used. The dose is 50 to 100 mg per day. Azathioprine. The side effects are nephrotoxicity, hepatotoxicity. Other drugs are cyclophosphamide, tacrolimus, mecofenil, mofetil, and plasmapheresis. They will remove the circulating autoantibodies against acetylcholine receptors from plasma. Patient condition improves rapidly, but effect is short-lived. Plasmapheresis used along with the IV immunoglobulin for myasthenia crisis. 5 exchanges are done over 2 weeks. They may reduce pseudocholinesterase, so there may be a chance of scoline duration of action. IV immunoglobulins. The dose is 400 mg per day for 5 days. And a rapid improvement which can last for several weeks. It can be used in myasthenia crisis. Last one is thymectomy. Less than 25% undergo resolution after thymectomy. It mainly due to decrease the immunosuppressive drugs or to induce remission. It is indicated with generalized myasthenia gravis patients. The contraindication for thymectomy are pubertal children, those patients with only ocular symptoms. Coming to pre-operative assessment. Elective surgery should be performed during stable phase of the disease or with minimal immunomodulator medication or glucocorticoid. Patient should be reviewed with history of muscles involved with and duration and severity of the disease, and history should be taken about bulbar symptoms like dysphagia, dysarthria, nasal speech, low intensity speech, cough, which may predispose to aspiration in postoperative period, and any respiratory muscle weakness, shortness of breath, or dyspnea should be reviewed. And we should take the history of pyridostigmine dose and any history of myasthenia crisis and need for endotracheal intubation. And patient usually have other autoimmune disorders like thyroiditis, rheumatoid arthritis, SLE. These also should be evaluated. Lab investigation. CBC should be taken if patient on immunosuppressant because there may be a chance of postoperative infection. Thyroid function test should be taken. Serum electrolytes, mainly potassium. Hypokalemia increase the muscle weakness. liver function test and renal function test should be done in immunosuppressant on medication. And preoperative ABG pulmonary function test should be taken to help in extubation postoperatively. A serial functional vital capacity measurement for the respiratory result should be taken, chest X-ray and ECG. ECG mainly pyridostigmine causes the severe bradycardia in perioperative period. We should evaluate for the perioperative arrhythmias. CT MRI for thymus and test for SLE bone densitometry in older patients. Preoperative preparation and pre-medication. Patient should be admitted 24 hours before surgery, and perioperative physiotherapy and incentive spirometry should be done. Patient should be informed preoperatively that there may be need of postoperative mechanical ventilation. The predictors of postoperative mechanical ventilators are duration of the disease more than 6 years, known case of COPD, pyridostigmine dose is more than 750 mg per day if vital capacity of the patient is less than 2.9 liter. Anticholinesterase should be discontinued if mild symptoms are continue in dependent patient because these drugs can lead to vagal arrhythmia and decreased metabolism of local anesthetics, mainly esters like procaine, tetracaine. Immunotherapy is avoided to prevent postoperative infection. Steroids to be given if patient on steroid treatment. Glycopyrrolate IV to decrease secretion. Anti-aspiration prophylaxis should be given. Opioids should be avoided in pre-medication. If pre-medication is necessary, smallest effective dose should be administered incrementally with continuous monitoring for signs of bulbar weakness and respiratory compromise. Coming to choice of anesthesia. Regional anesthesia should be considered for peripheral procedures that can be done under regional anesthesia. A mild local anesthetic should be preferred over esters because anticholinesterase used for the treatment for patients with myasthenia gravis may theoretically impair the hydrolysis of ester local anesthetics, results in prolonged block. Coming to general anesthesia, the goals of induction is to prevent prolonged effects on respiratory and bulbar muscles to allow rapid recovery and at end of surgery, and neuromuscular blocking agent should be avoided when possible. Inhalational agents, a potent inhalational anesthetic provide dose-dependent neuromuscular relaxation in patients with myasthenia gravis. They provide adequate relaxation for endotracheal intubation and surgery, possibly equivalent to the level of relaxation achieved in neuromuscular blocking agents in normal patients. Recovery occurs as inhalational agent is eliminated without need for reversal agent. Intravenous agents, they use it for induction and maintenance. Here, short-acting propofol is commonly used with dose of 1 to 2 mg per kg because it is rapid in onset and short duration of action, and it also suppresses the airway reflexes. Remifentanil, ultra-short-acting opioids, is particularly useful for intubation while avoiding neuromuscular blocking agent with the dose of 4 to 5 microgram per kg. Propofol and remifentanil provide good to excellent intubating condition at 2.5 minutes after induction. Ephedrine should be ready because to avoid the profound bradycardia and hypotension that may result from the dose of remifentanil. The combination of medication can be used for rapid sequence induction. And succinylcholine, it causes a variable response in patient not on anticholinesterase therapy. There will be a resistance to acetylcholine due to reduced functional acetylcholine receptors. Patient receiving anticholinesterase therapy, there may be a decrease in plasma cholinesterase and increase this choline at motor end plate, which can lead to increased duration of action of this choline. Plasmapheresis should be done if there is increased duration of action of scoline. Non-depolarizing neuromuscular blocking drugs. Myasthenia gravis patients are extremely sensitive to non-depolarizing muscle relaxant because there is a decrease in acetylcholine receptors up to 70% in myasthenia gravis patient. It can lead to profound weakness even to pre-chloralization dose. Atracurium, cisatracurium relatively safe because they are short of a small volume of distribution, lack of cumulative effect, high clearance, and spontaneous reversal. Long-acting non-depolarizing muscle relaxant should be avoided. The monitoring of standard ASM monitoring, temperature, ETCO2, CVP if significant fluid shifts, urine output, neuromuscular monitoring at one or more sites due to uneven muscle weakness. Maintenance with volatile anesthetic without N2O, atracurium, cisatracurium are preferred. Non-depolarizing muscle relaxant maintenance dose should be 1/3 or 2/3 of initial dose. Control ventilation for adequate gas exchange. Remifentanil-like short-acting opioid should be used. Dexmedetomidine is avoided as it aggravates the centrally mediated increase in vagal activity due to pyridostigmine, which causes the bradycardia and arrest. Extubation criteria. Patient should generate negative inspiratory pressure more than 20 millimolar Hg and peak occlusion pressure more than 30 centimeters of water, force vital capacity more than 50 ml per kg with sustained head lift more than 5 seconds, and able to maintain normocarpia and adequate oxygenation. Reversal of neuromuscular blockade is recommended with sugammadex rather than the neostigmine. Adequacy of reversal should be confined whenever possible by train of 4 more than 0.9 using quantitative train of 4 peripheral nerve stimulator. Postoperative care. All patients with myasthenia gravis should be closely monitored postoperatively in the post-anesthesia care unit, where respiratory support can be immediately reinstituted. Weakness after surgery presents a special problem in myasthenia gravis because there may be a different diagnosis include myasthenia crisis, residual effects of anesthetic drugs, non-anesthetic drugs interfering with the neuromuscular transmission, and cholinergic crisis. Adequate postoperative pain control, pulmonary toilet, and avoidance of drugs that interfere with the neuromuscular transmission will facilitate tracheal extubation. Thank you. Thank you, sir.
Nice class.
Thank you, sir.
Yeah. This class will be useful for the postgraduate students.
Yes, sir. Yes, sir.
Yeah, every point is covered completely. Please share the PowerPoint so that they can keep it in their notes. Okay.
Okay, sir. Okay, sir. Sir, any added points?
The only thing is, in my experience, I gave muscle relaxant for only one case, which needed post-operative ventilation also, because the major issue is at the end of the case when you give neostigmine, the muscle power regains abruptly.
Yes, sir.
But after 10 minutes, again the muscle weakness comes back.
Because of cholinergic crisis.
Because of the cholinergic crisis, again the muscle weakness comes back.
Okay.
That patient needed re-intubation also.
Okay, okay.
Yeah, that is the only case that I remember in which I gave muscle relaxant. Otherwise, we generally maintain without muscle relaxant in deep sedation.
Okay, sir. Okay. Thank you.
Okay.
జయరామ్ వచ్చాడా?
మాస్టర్ వచ్చా?
మరి ఇంకా మోడరేట్ చేయమని క్లాస్మేట్.
మాస్టర్ ఇలాంటి పనులు మాకప్ చెప్తారేంటి?
Any doubts, added points, your experience with myasthenia patients?
Hello.
Good morning, madam.
Good morning. Morning. I think if I remember what Shekhar mentioned, that case, is it the one in Unit 2, Shekhar?
Yes, madam.
Yeah, I remember that.
That patient again admitted for CABG and he was on prolonged ventilation with tracheostomy also.
Yeah, that's what I was going to say. This patient came for another surgery. I think it was for thymectomy, Shekhar.
Thymectomy. Yes, thymectomy.
He had thymectomy in CTOT and he was in in recovery. They extubated him after elective ventilation for a day. They tried extubation. He needed reintubation. After 2 days of pressure support and gradually weaning, we tried extubating. Again, failed extubation. He needed reintubation. So for these cases, we have to be like prepared for prolonged ventilation on tracheostomy and gradually wean him off. Like suddenly, if we take the supports off, they won't maintain. They maintain for a little while, then gradually they. How do you know that they are not maintaining? We have to do ABGs. PCO2 will build up because of hypoventilation. We may see saturation okay with little bit of supplemental oxygen, but they will get fatigue and with hypoventilation, CO2 will build up like anything. So, and they'll need ventilation again. So, we tried, we had to go for tracheostomy. Then to tracheostomy, we connected this BiPAP machine, which can be connected to trachea, and then gradually weaned off over a period of 1 week or so. So for these cases, we have to be prepared for prolonged ventilation, tracheostomy, and in post-op period, they need more this one, like a pyridostigmine doses, and also like if they don't respond, they may need immunoglobulins or plasmapheresis. Can't remember which one he had, but he did take a long time to recover and come off BiPAP and ventilator. And after that, like he came to me one day, like both times I was involved. So he remembered me, and afterwards he came to me. He said he has varicose veins or something vascular thing. He wanted to go for surgery. Can he go for it? I said, if you can avoid any surgery, please avoid. We had enough of you already. So any surgery, unless it's for life saving or limb saving, we should try and manage conservatively. I told him that way. So I don't think he had any more surgeries after that. Thank you.
Irony is he's a friend of my father.
Whose friend?
My father's friend, madam.
Oh, okay.
They are colleagues at work.
Oh, okay.
Anyone else having experience with myasthenia patients? So I had in ICU, but OT I have not done anesthesia for myasthenia gravis. Any additional criteria, madam, while weaning for extubation and all? Anything else we have to take, monitoring or something like apart from ABGs, which you mentioned, Shaker?
Yeah, I think if we can do as Ganpati mentioned, ideally we should check for vital capacity in maximum inspiratory pressure and expiratory pressure, all those. But I don't think we have checked those. But you should see that with minimal supports, they should be able to take good tidal volumes. And like we had to put him on pressure support, like on BiPAP machine overnight and take it off in the daytime. So like that, we gradually prolong the off time. So to see if he's maintaining okay. And we used to do ABGs in the off time, like if he's off BiPAP in the morning, we used to do late afternoon like that to see off BiPAP how his ABGs are. Not like first thing in the morning. There's no point doing there. So like that, we tried. But ideally, you should check these pressures and vital capacities.
My only suggestion is whenever you encounter these myasthenia patients, please give them a priority and keep it as the first case so that you can monitor whole day. Otherwise, if you keep it in the afternoon, the monitoring will be not much better. It's better to do it in the first half of the day and monitor the patient, and you can extubate them, most of them by evening. Otherwise, you don't be in a hurry to extubate the patient like normal cases. That's the only thing I can add. Because they appear normal, but they land in crisis again. After when we extubate most of the patients, they need at least pressure support ventilation through mask.
Okay.
Kiran, Omkar, any experience? Okay, fine. Thank you, Ganpati.
Thank you, sir. Thank you.
To keep the PPT in group month, and
Okay.
any special review articles like that, if you found it good during preparation of study, please keep them also.
Okay, sir. Okay. Thank you, sir.
Okay, thank you. Fine. Bye.
Bye, sir.
Thank you, everyone. Thank you, Rani Madam, Shaker, the valuable sponsor. Bye bye. Have a
Thank you.
nice day.
వస్తాను సార్ కలుస్తాను సార్ ఏ టైం ఉంటుంది సరే సార్ మీకు ఫోన్ చేసి వస్తాను సరే అక్కడే సార్ సరే గుడ్ మార్నింగ్